you know, being retirees, the healthcare programs are costly to the city. We hope to continue the benefit as it is now for all of us. We have about 1,100 members, including our dependents. So the city considers our health program, our health and wellness programs, a very important component of our workplace, and of course, when we need coverages, it's there for us, and we still maintain a very generous benefit for all of us. So the idea is to continue that. I think this meeting is timely because now we're beginning the budget process, or thinking through the budget process as we go through the summer months, not only for the active plan, and we're going to talk about how we've encountered a few challenges over the last 2 years, particularly in terms of the cost of the plan that affects all of us. And then also the renewal, we have renewals for our fully insured plan that protect some of you, particularly if you're Medicare eligible. So we've got a lot of things that are going on, and our idea is to continue with the benefit and proceed through it with some plans. So we want you to share in our experience here, have a discussion. We're going to go through some slides. Jan Bush is representing us and helping us with our program. Tom Abate is here, our assistant city manager. I see Scott Maurice, our city manager, is here. So we're all concerned about about health care as we move forward. So I think we've got. Does everybody have a handout? No. You've got some. Okay. We're making some more copies, and we'll have those up. But why don't we get started? I'm going to ask Jan to go through the slides with you, and then we're going to have some opportunities for some discussion, and then at the end we'll kind of wrap up and kind of decide and think about where we're going to go from here. So, Jan, you want to take us through?
Good morning, everyone. Good morning. I'm Jan Bush. I'm with Robinson Bush. We're benefits consultants for Orlando, and I've been working with Joe and the team here for a number of years. My partner, John Robinson, is probably someone you've seen in the past. And what we're doing today is we're not making any recommendations. We're not presenting a proposal. This was really at the request of your city council members to come and get your feedback about what's important and how we can go into the future to try to preserve your benefits as well as possible, knowing that there are some struggles, and we'll talk about a few of those from the health plan's perspective. So everyone will be having a packet to take with you, but I wanted to start by reiterating the city policy right now for retirees. So as you probably know, it did change on 10/1 of 2003. So if you were hired before 2003, October 1, and you retired before April 4th of 2014, the city policy at this moment is that 100% of your employee-only health plan will be paid by the city. So that is the city policy, not to exceed $500 a month. So that was something you guys. That's the city policy that I was made aware of. So
yeah, and a couple years ago, about 2 years ago, the program was capped at the $500, and that was part of the city policy. So we wanted to share that with you for those of you that aren't aware of it.
You're going to share that with us 2 years later?
Yeah, well, this was part of the policy that happened then, and we're, part of the discussion is going over this at this time. So
Well,
We're letting-
one of the numbers I'd like to have front is how much has the city saved since 2003 by not paying for the new hires' insurance. You know, all these numbers they're gonna come out with are saying that the city can't afford this, that. We're showing you twice we changed, and we've saved the city millions of dollars. And everyone in this room is supposed to get health care for life, 100%. No caps, no nothing.
Okay, I appreciate that, Don.
One other
But
note.
let's,
One other note, Joe.
okay, go ahead.
The city manager at the time, Mark Ryan, had sent out a memo that said if you don't leave before 4/1 of 14, you would be capped at $500 if you left after that point. So therefore, there's folks that left prior to that, myself included. I left in January, and that lifetime medical, the premium being paid full, the entire premium, was still in place. So now, if we're going to cap it at 500, some of us who left early just got hosed out of 6 months of pay and dropped. You follow me? Because that wasn't in place in January of 14. That memo came out and said effective April 1st, if you don't get out by then. And I've got the memo in my files to verify that. So I don't see how we can retroactively go back and cap that, for one, or anybody's health care that gave the majority of their adult lives to this city and has been loyal to this city.
Okay. Well, let's keep, and I appreciate your concerns, and I know those concerns. I think I've had, that discussion even with Don, a couple years ago, and we talked about, the threshold or the limit. So, but let's keep going through this process, okay? We've got some information we want to share. I think we got to get beyond this and move forward, and where we're going to go from this point on in the future to continue to sustain this benefit, and we'll stay below that limit. But I think we have to keep that in mind as we go along to again sustain this benefit. So let's keep going through that. If you have any additional comments.
Well, I can tell you that I work with a lot of public sector groups. We'll talk about the Florida statute that requires the continuation of retiree benefits through the state law. But this is a very difficult issue, very difficult for many, many employers. And as healthcare costs have continued to rise, and you've got active workforce that you've got to take care of, and the people that did serve their adult life to the city and to their employer. So believe me, this is not easy for anybody to stand up here and talk about, because it's a very problematic issue for many, many employers and many of you that sit here that have to deal with the future of your security and your health benefits. That's a very important issue, and I don't want that to go unrecognized by anybody here. So after 2003-10-1, the policy did change to a years of service model, so it's $8 per year of service. So that did change for anybody that was hired after that 10-1-2003 time period. So people will start moving into that category, but it will be quite some time before that policy really has a full financial impact. The Florida statute that governs how cities and counties and school districts in Florida have to provide continuation of coverage upon retirement is Florida Statute 1120801. Basically, it says that the employer needs to offer retirees and their dependents the same health and hospitalization insurance coverage that's offered to your active employees at a premium cost of no greater than that of an applicable active employee. So retirees do have the ability to continue. Now, what the statute doesn't say is that the employer has to pay for that coverage. So that's a city policy or an employer policy and how you provide those benefits. But the statute says that you do have to provide that opportunity to continue to participate on that governmental plan that you've been on. Now, once you age into Medicare, become Medicare eligible, the statute has a little different language attached to it that says that you can be experience rated separately from the retirees that are not covered by Medicare. So again, provided that the premium doesn't exceed the premium of the active employee and that the coverage is basically the same. So any of you that maybe were on the old plan and have now moved into the new plan know that once you aged into Medicare, Medicare became your primary insurance company, and then if you were in Cigna, that became your secondary coverage. Or if you went to the Medicare Advantage plan, that became your coverage, period. That was your health plan. That is your health plan if you're in that Medicare Advantage plan. So I wanted to give a quick update on the status of the self-funded health plan, which this is the active plan, and the retirees that are not Medicare eligible are in the self-funded plan. And what that means is that the city basically takes the risk for the claims costs. That's the city dollars. Every dollar that gets spent on a claim is paid by the city. There is insurance that's purchased at a high deductible level to protect from those high-cost catastrophic claims that do occur. In fact, I think there are about 10 of them that are out there right now that are very unfortunate but high-cost claims, but that portion of the plan is insured. Now, on page 5 of your handout, you can see a grid here that shows from the last fiscal year that ended on 9/30/2015. The way this looks, you see the income at $4.5 million. The expenses were $6.6 million. So you can see that the plan lost $2 million in that last fiscal year. The city had to put an additional $2.6 million into the fund to cover those claims costs and keep the plan solvent, leaving a reserve balance. And I will tell you that the Office of Insurance Regulation that governs these self-funded plans requires you to have a certain reserve balance in order for them to determine the plan to be financially solvent. And that safe harbor is 60 days of expected claims costs. So the state looks at the self-funded plan. It's required annually that an actuary certifies the financial solvency of the plan and submit a report to the state showing that you have sufficient funds to cover any claims costs. The last thing they want is for someone to have $1 million claim and the employer doesn't have the money to pay that claim, and then you've got a consumer out there that's stuck with a big claim. So the year that we're in right now is that second column in that fiscal year ending 9/30/2016. And if you follow that down, you can see that the actuary's projection was that the plan was going to lose about $700,000 this year that we're in. And the city is having to put some additional dollars in this year. And unfortunately, the way that the claims costs are tracking this year for the first 7 months of the fiscal year through April, it looks like the expenses are going to exceed $6 million. Again, a lot of that due to those high-cost claims, and just the fact that inflation and healthcare costs are continuing to rise. So we're looking at a reserve balance that's going to keep going down, and the city is having to put more money into the plan. So just wanted to frame that's really the crux of the dilemma that the city is dealing with. Is we want to preserve the best possible health plan for everyone, and ergo the dilemma that is the reality of the situation, which is the plan is not at this moment bringing in enough revenue to cover the expenses that are occurring in the plan. So we're on slide 6 for anybody.
The insurance that you talk about on these higher, where is it here? Does the city collect that money? And if so, where does it show up?
So that becomes a credit or an offset to the expense line. So in other words, if someone has a $500,000 claim, and I don't remember what the deductible was, but it's $135,000. So once paid claims exceed $135,000, you have insurance to reimburse. So if you had someone with we'll make it easy, a $200,000 claim, the city would get $65,000 back, and it would go back into the self-funded health plan.
Okay, so it is.
It all stays in a fund that's earmarked for the health plan expenses. So that's it's all part of the self-funded health plan. The premium is also charged to the health plan. So yes.
Okay. I'm looking at this what you're talking about. The game law, second column, says fiscal year 9/30/2016, $16,000. At the May 10th council meeting, there was an announcement that there's a $3 million loss, catastrophic loss, and that the city's going to have to take care of. So that was due to something like 7 or 11 employees with catastrophic illnesses. So it appears to
understand the 3 million in claims is total claims of the city, not just the catastrophic losses. Catastrophic losses accounted for about a third of that. So we are trending, that 3 million is trending about, above what we've already budgeted. So at that May 10th meeting, what we asked the council to support our additional funding of about 670,000, I think, to put into or replenish the partially self-funded plan so we can pay for those claims coming up. But I think that 3 million, you may be getting that confused with the total claims. It's just not just the catastrophic losses. This information that you have here is taken from the state required report that we have to submit each year to the state. So I hope that clears up a little bit.
When you say training, I don't see anywhere that it's represented. $3 million. I don't see it.
Yeah, and that report, and the report is anticipating, this report was prepared in what, November, anticipating what may occur this year. So that column, is not, it's a report looking ahead and preparing for the fund.
And you do these projections based on what you know at the time, and you don't know how many of those catastrophic claims you're gonna have, so you're looking at trend. So what is your medical trend running, and what are your claims costs, and then you project forward. It's a crystal ball, but there is scientific methodology behind it. But actuaries have the job that you're wrong 100% of the time, because you can't really predict how those catastrophic claims are gonna happen from one year to the next. So that goes to the comment of when we looked at the annualizing your claims that have occurred for the first 7 months, it looks like your expenses are gonna go well over 6 million this year. So that 680,000 is a low number. It will be a greater loss, and that was kind of the point of, the fact that the city's gonna have to be putting more money into the plan and had to go to the council and ask for some additional funding. It's concerning. It's concerning. The actuarial report and the state requires you to go 2 more years out. These numbers really are so far out into the future. They'll be updated again. So these numbers are just so you know this is what the actuary put on the report. And to be honest with you, that $680,000 loss, assume that you were going to put a pretty good increase in the plan. So there is going to have to be some additional premium revenue that's going to have to go into the plan to cover those expected expenses. Any more questions on that?
I just have a question. I need you to explain to me why this is a self-funded plan and we're covered. Why are there even premiums attached? Why is there a premium cap of $500? I mean, well, then why can't they take that extra money and buy a cap policy that goes over a certain amount, where it would then pick up the premium?
Well, you could. I mean, when you're self-funded, you look at premium equivalents, if you will. So if you were fully insured, for instance, Cigna or Aetna or any of these insurance companies would look at your risk and they would say, well, you've got this many employees, this many dependents, this age, this demographics of female, male, and we're going to underwrite what we think your expected claims costs are going to be. And then they'll set the premiums for you. Self-funded is really not that much different, only it's your money. So you have to underwrite risk. Whether it doesn't really matter who's actually taking the risk, if it's the insurance company or you as an employer, but you have to set those funding rates at some level that you think is a reasonable level that will cover your claims expenses and the way that people enroll and the way that people use your plan. So it's you make those adjustments when you need to, but if you don't spend what you're taking in, you keep the money as a self-funded plan. If you're insured, and let's just say those premiums were $6 million, but you only spent $4 million, that money stays with the insurance company. So that's really the risk sharing or the risk reward. And you do pay premiums for your stop loss. So you do have a deductible of $135,000. So any individual that has a claim that's paid over $135,000 is insured. So the city gets that money back. So you do cap your risk with your stop loss insurance. There is insurance that you can buy called aggregate insurance. I don't think you buy aggregate insurance, do you? Which would be the risk for the whole plan. But again, underwriters will look at and say, well, we think your claims are going to be $6 million, so we're going to add a 25% cushion to that, and we're going to set your point where we can start reimbursing you 25% higher. So that's a big miss, to miss 25% on your expected claims cost. So most employers of your size don't purchase that insurance because it's really hardly ever going to pay out. So it's just a waste of premium. Did that answer your question?
Not really, but it's,
Well,
I mean, I can see the cost bigger than a premium for, your spouse and your children, if you still have them on your plan. But if your insurance was supposed to be coming to you 100%, there shouldn't even be a premium amount listed to it.
well, the city pays the full premium for the employee-only coverage tier, correct? You don't have.
You don't really take, you pay it yourself.
It stays in the self-funded plan, right? You're not giving it to an insurance company, you're keeping the money, you're the insurance company, basically. But the employees pay zero.
So far. That's what we're here for, we're worried about.
I understand, I understand. So any other questions on the financial, on the self-funded health plan and where things are with that, which is a different.
In the actuarial projections, did they take into account those employed after 2003, those hitting the Medicare age? How many actual employees do you have in that sector, and how long before that group moves out? Because we're looking at a long-term fix for perhaps a short-term problem.
Well, I could get with the actuary and see what credit or what type of decrement in the expense they gave to that.
It would appear there wasn't.
Yeah, well, we can get with the actuary. That's a good question. I'm not sure what methodology the actuary used for that.
Talk about the OPEB liability.
No, I'm talking about that group of employees, active or retired, that fall under the 03 change, $8 a year. There's gonna be a big decrease in retiree healthcare costs.
Right.
Once that group really
That's a number of years out.
Yeah,
Yeah, I'm not sure how many years that is.
Increase the OPEB liability.
That is,
Right now, it's about $40 million.
yes.
when does that start dropping
Probably
down?
not for another 15 years.
So on page three has that there were 327 total people in that after 2003, hired after 2003. It's the very bottom of page 3. You have one retiree that's already been retired that falls into that category with the $8 a year of service. But you've got 326 in the pipeline for that.
And do we also look at the number in the group now that we're saying the Medicare, that also?
So yeah, and if you take the difference, so the people in the first line where it was hired before 2003 and retiring before, there are a total, these were updated numbers that we just got, but 273 people fall into that category. Of that, 159 are already Medicare eligible, so 114 are still retirees or employees not Medicare eligible that will fall into
That was the 2014.
that they retired before 2014.
They're retiring, okay.
And then the middle one is retiring after 2014.
So this is basically a group of 114.
In that top category. In the top category that fell into the old policy. That'll continue to get smaller. Which is, again, that the policies were made to try to have that impact over time, but it will be a while before that is fully realized from a financial perspective. Another
That
quick
would be
question.
114 out of how many? 1,100 members now?
That's total members. I think employees, we're talking about 716. I think about 716 people. 480 active and the rest retirees. Quick question here.
Actually, the.
I'm just curious the name of the actual.
Right, Jay Mignetti is the actuary, and the cost of preparing this report that has to be submitted is actually paid by our reinsurance carrier, Symmetric.
So, any more questions on the financial, page 5? Page 6 is just reiterating the 3 plans that are available for the non-Medicare retirees. It's the Cigna plan, and any of the non-Medicares know that that's the plan benefits that you have today. And for the Medicare eligible retirees, you have the option of 2 plans. You've got the Cigna Medicare Surround, the Medicare Supplement plan that comes in behind Medicare. That's Plan N, with the comprehensive prescription drug plan through Cigna. And then Aetna Medicare Advantage prescription drug plan, and these are both fully insured plans. So these are not part of the self-funded plan. Non-Medicare eligible retirees are commingled, and they're a part of the active employee plan. And once you're aging into Medicare, those plans are now fully insured. And someone touched on the OPEB, I guess it was Tom, but you know, your GASB 45 or your other post-employment benefits liability that you have to record every, so often on your balance sheet is positively impacted by not having that ongoing self-funded liability. So now I think this is, again, no recommendations. This is not a proposal, but I think we're kind of wanting to get into the more interactive part on what you see in terms of ideas. And the council really wanted to know what you're thinking about. So we thought we'd start with the non-Medicare eligible retirees, and I don't know how many of you are in the room, but so would it be appealing to you to have lower cost plan options and then have buy-up options? Would there be any interest in a stipend or some amount of money to say, I'm going to go out and I'm going to go into Obamacare, I'm going to go into a marketplace or something like that? Would it be appealing if you were to opt out? This is a recommendation, just feedback. I know that the employee health clinic is very important to a lot of people, and so would it be appealing to, if you were to leave, for instance, the sponsored plans, to still, as a retiree of the city, be able to continue to use the employee health center? So those were just some ideas on the non-Medicare folks. The Medicare folks, right now, the statute says that you have to provide benefit plans that are similar, not the exact same, but similar. Medicare plan, the Plan N and the prescription drug plan, we think provides you with that statutory requirement. Would there be any interest in the in additional Medicare Advantage prescription drug options that might be lower cost and maybe a differential and a stipend or something that would say, hey, I'm pretty healthy, I don't use a lot of health care, I'm overinsured because I don't really have prescription drug needs or I don't have other needs, and there's a zero premium plan that I like, but and I could use the extra X amount of money in my monthly pension check. So, those are the kinds of things we wanted to somewhat get your feedback about, whether you would see any of those things of interest or appealing to consider. And, again, going back to the employee health center, that once you become into these plans, that's not available to you anymore to use those health centers. So would that be appealing to you to be able to continue using the providers in the health center and opting out of the sponsored plans or whatever that configuration might be? So at this point, I think we wanted to open it up to feedback on what you think would be a tenable.
We're opening up now. I think it's probably going out on a limb by saying that it's 100% probably in favor of our expectations to go back this input to council, say we met with retirees and the A, B, and C are items that they want you to consider. Would it be 100% agreeable that you guys are in favor of lifting the $500 cap? Is that something that is?
It shouldn't be in place in the first place.
So let's get that out of the way. You feel that you were promised, health care for life at no cost. This $500 cap you rejected. So that's going to be an item that we'll set the council. They unanimously understand, and we're gonna go back to council with your input in that regard. Now, let's look at some other options that, if council would say no, that we can present, so.
Yes.
Civil litigation.
I have more than one question, but one question I have concerns both non-Medicare and Medicare. And that is that I chose when I retired to have dental insurance. There's been no mention of dental insurance, but it is a major expense in my family. And I'm hoping that it will continue, that I'll be eligible for that. And I would like some assurance today that it will continue because it is a major expense. And the dental insurance plan is, as far as I'm concerned, is fantastic.
So I can tell you that I can't give you assurances, I can't predict what council's gonna say. However, staff has no intention of approaching council with any changes to the current status regarding
But it's
dental.
not
And the scheme of things, what?
I'm concerned that it's not even mentioned in this meeting.
Because we haven't even, it hasn't even come up for discussion.
It's not mentioned, the dental plan, I think you're aware, for those members who retired, I think we made some changes there in the dental. You retired, pre-2014, around that time, you were allowed to continue with dental coverage at 100%. And I think that's what you're referring to. After that date, the city discontinued, that benefit, and if you retired after that date, then you paid for your dental. Okay, so the interest is to continue along with that. We're not going to go back and think in terms of removing that benefit. We didn't think of it in terms of this medical expense because it's not a significant cost as the major. But just to reassure you, and I appreciate it. It is. You're right. If you have certain expenses, I don't think the expectation is to go back and remove that from your benefit. Okay.
Dental plan is in good shape, it's not basically.
Yeah, we're actually right. We actually have a surplus at the end of the year. That's not really the concern of the discussion. Is more on the major medical.
I'd like to see numbers, okay? And with all of these things like stipend in or stipend out and cost, I mean, this is just something that I want to see a number. Like if you wanted the stipend out, what's the dollar value a month? Is it at least the dollar value amount of what the coverage is?
What would
I
it
think that's
require?
what we should see.
What would be enough money for you to opt out? What would be the minimum amount of money that you would say, we don't know what would be entitled, that's why we wanted this feedback, because we could say any dollar
That's
amount.
why I think we need to see numbers that you are offering. That will make a decision. I mean, you may have somebody that's going to opt out for $100 a month, and somebody else that says, well, I'll opt out if it's the full value of my medical insurance. I want to see numbers. I don't want to just see what they're thinking about doing this. Let's see what it's going to be.
So you want something, a proposal then, this was
What-
really feedback, but you're looking for,
Obviously, we can offer more than $500.
right. So just for the sake of conversation, let's use $500 as the number. Okay, it's $500, so here are your options. You stay in the plan, and it's covered, and the cap's 5 or whatever it is, that may go away. But let's just say it's $500, and we said, if you wanna opt out, and you wanna take a zero premium plan, or you wanna go to the marketplace, or you wanna do something else, we'll pay you $500 a month to opt out of the city's plan. Would that be something of interest?
From a realistic standpoint, though, whatever it is, what cost would actually give us the same coverage out in the marketplace? In all honesty, it's going to be awful high. So it's going to be probably more than $1,000, to get the same type of coverage.
It
So
should
we're
be
not in a real world opting out situation.
Well, I think it depends if you're Medicare or non-Medicare eligible.
Right.
If you're Medicare eligible, there are a lot more options, a lot more affordable options for you. And so if you're Medicare eligible, let's start with there. If you're Medicare eligible and the incentive for you is to say, we'll either allow you to enroll in these plans and we'll cover the premium, or we'll give you up to this amount of money, and you can go look on the marketplace or in the, Medicare supplement, Medicare Advantage, zero premium, all of those would be open. Well, I don't, no disrespect, but the people that are leaving are retirees, so, so those aren't the best risk for the plan. I'm not just being honest about that, so.
Now, those are fully insured plans, so I guess the question is if those fully insured members left, let's just, all right, let's just follow up on your question. If the people opted out who are covered under the fully insured plan, to what extent to those other members who stayed in the fully insured plan have that impact? Now, I'm not sure on the fully insured. Maybe you might know a little bit better of how those plans, how those costs over time either increase or decrease depending on the membership.
Yeah, I mean, you're commingled with other fully insured people beyond what the city has when you go into these fully insured plans. Self-insured, I mean, your point is well taken. You're making a good point. The fewer number of people you have to spread risk among, the more risky it becomes. So that's something you have to look at all the time. And so I think evaluating your options from the self-funded plan is obviously something that is an important strategy to do. But the issue is you've got new hires coming in that are younger, active employees, and you've got a pretty good-sized group of retirees that are almost half your people. So the strategy is, how do you do the best for everyone? And that's really the reason why we're here, is to say what are the options, and your feedback's great. This is what we wanted. So we're just here to ask for your feedback on what would an opt-out be for you. Obviously, if that was a strategy, we'd have to put the numbers to it all and do all of those things in the evaluation. But at this point, where we are in the process is, what's something even to go down that road and look at, or this just is a flat out no, we're not even interested. Generally, when you go that direction, it's an opt-out that's irrevocable, that once you opt out, you're out. And I think, I'm glad you made it. Well, and That's a good point, and I will tell you that those plans do exist on a group plan. And for a group plan, you can get that donut hole, that coverage gap, full coverage through that gap. And as a matter of fact, the city participated in an RFP with Brevard County, looking for Medicare Advantage and Medicare Supplement options. And one of the plans does have that full coverage through the gap. It happens to be in South Brevard County, but you can get those plans. And again, that would just be a consideration. Would we want to RFP and say, hey, we want a group Medicare Advantage plan with full coverage with the expanded bonus drugs and the prescription drug plan with no coverage gap? We could get that. Now the premium for that plan down south, and it's available up here too now, but they don't have Parish Medical Center in the plan. It's $177 a month. That's the premium for that plan. And it's got full coverage through the gap. It's got, comprehensive co-payments. If you go to the doctor, it's like $10, $15 to go to the doctor, and it's a very rich plan. And again, those group plans, Medicare subsidizes the medical portion as well as the prescription drug portion of those plans. Medicare Advantage. The network. Now, some of them do have out-of-network benefits. And I was just giving you an example. I'm not saying that works here.
I'd like to comment on that. To me, the Medicare Advantage plan doesn't work at all. It doesn't cover the hospital I use, the doctors I use. I'm not a person who uses Parish, unless I got this in high school. For me, if the Medicare Advantage plan under the Parish is now, I would definitely opt out. So don't say that just because you live in Titusville, there's a lot of retirees who live up north, who live out of Titusville.
There's not one solution that fits for everyone, because everyone in here probably has a different need and a different use of how they use health.
That's why it's called an opt-out. You don't have to take it.
Yeah, so
Some people may find it attractive. We want to provide a menu of different options. We want to get your input as to which one are accepted. Like, that Richard lives in Merritt, I happen, he may want to get a different facility where the opt-out is in K will benefit him. But those here, may not. So again, it's not one size fits all. We're trying to give you more options.
and some options that might be appealing to some people, not everyone, might be to opt out and take a stipend and go out and buy your own, program that that is more suitable to your healthcare needs, and take the difference and use that to vacation or whatever. Yeah. We don't have any details at all. We're not really making any proposals on any details. Yes.
The 114 people that retired before 414 and were hired before 10/1 of 2003. Have y'all done an analysis of how close they are to Medicare age? What are we talking about in terms of those 114 people? How long?
Well, we got about 80 of them here, so.
Well, I guess the question I've got is, why haven't you? I mean, I'm assuming you said you did, you're not quoting me anything, so why haven't you in terms of evaluating this quite clearly? Why don't you know that? You've got all the records. And, I get what the city's saying about money, but from a retiree standpoint, it's a matter of trust. I mean, I consider what we're doing today, you're asking us to put our fingerprints on a bloody knife. We've done that many times before. And then you suck in. I'm one of those that was hired before 2003 and retired before 14. I was told I would never have to take it. Never. Now, all of a sudden, with very little discussion or concern by council or I think higher ups, you already said if you opt out once, how can we trust you that you're not gonna screw us over again? You've already said that most plans is forever if you opt out. So, what's gonna make this change from anything that councils and administrations have done over the years? Where is our guarantee that, once again, if we help you by decreasing what we've got right now, what's to say that you aren't gonna decrease it again, and again, and again, and again? You've got, I'm gonna talk just about my group here. You got 159 and 114, 273 total employees. I'd like to know their ages. I'd like to know how long before they went Medicare available, because I would think that would be an important thing for y'all to do. And I'm not really sure that it's fair for the administration to ask us what we'd like. What I'd like the administration to say definitively, you're not gonna get this coverage anymore. Now what do you want? Because otherwise, once again, you're asking us to put our fingerprints on that really nice part of it. And I don't hear anything today that's definitive